I'm sitting with Dr. Benjamin Warf, the professor of neurosurgery at Hardvard Medical School. Doctor, welcome to the gathering.
Thank you.
We're really delighted you're with us. Now, if I was looking on Wikipedia, I would be pulling out some other facts and figures that I think are significant. You also serve as the Hydrocephalus, which for our listeners and viewers is water on the brain, and Spina Bifida chair at Boston Children's Hospital. And you're also the senior medical director at CURE. In 2012, you were awarded the MacArthur Fellowship. We'll want to dig into that a little bit as well. And have served on the faculty of the University of Kentucky and Thomas Jefferson University. Now, when I was looking into your background a little bit, I also noticed Appalachian Mountains of Eastern Kentucky. And that just seemed to me to be a very wide gap. Tell us about where you grew up and maybe how did that shape you into what you're doing today?
It was a wide gap. I grew up in Pikeville, Kentucky, which is in the Appalachian Mountains. A small coal mining based town, at least in those days. My dad was a pastor. My dad had, and this gets into the conversation a little bit later, my dad had physical disabilities, which helped to shape some of my thoughts and feelings about that. And my dad very much had a missionary's heart. He was from the western part of the state, but we moved to Appalachia because he felt like that was a mission to a poor part of the country. And
had he grown up in a poverty area?
Yes, he grew up in southwestern part of Kentucky called Greene County, very poor circumstances. Grew up plowing behind a mule.
Wow.
And no electricity in the house. Those things that it's hard to imagine today. But Dad had applied with one of the mainline Protestant foreign mission boards when he was a young man. And he would have been very capable, but they turned him down because they said he wasn't physically fit. He has some orthopedic deformities. He still can hunt and fish and play golf, but he does have he does have some physical disabilities, and so they did not allow him to do what he felt like God was calling him to do, which has always bothered me a little bit.
How is it when you say it bothered you?
Yeah.
In what way?
Because I didn't think it was fair. I think that it gets a little bit into our, even today, perceptions of people that have particular sorts of disabilities. We tend to put them in a different kind of box. And I don't know what they were thinking, but it may have been similar to the reason that I was given by a mission organization that we were interviewing with for them not being able to send us. We felt called, my wife and I, to go do medical mission work in a part of Africa. And this very large mission organization told us that because of our daughter, who has some significant disabilities, including some that are rather disfiguring, they said they couldn't send us because it would ruin our witness. Because clearly, in that culture, people do think that people affected with these kinds of things are cursed. And so that would ruin our witness as Christian missionaries.
Perhaps that's different from actually showing that this is a child perhaps made in the image of God that actually has meaning and purpose. And
right. And as it turns out, when we finally did move to Uganda with Sarah, that's my daughter's name, that turned out to be a significant part of our ministry. Sometimes I think God sent us to Uganda because of Sarah, because of the fact that we were rich white American missionaries and we had a daughter with obvious cognitive and physical handicaps, disabilities, and yet she was part of our family. We had her out in public. We walked down the street holding her hand. Apparently that was rather impactful to people.
So disability in your own family growing up, but also in the family in which you're the father, has been a fairly significant subject from day one.
Yes.
How has that kind of shaped your own understanding as you chose medicine, but my guess is based on your background and the things you've achieved intellectually, you could have done a number of things.
Yeah.
Why global pediatric neurosurgery?
Well, it wasn't planned that way, I can tell you. When I was sort of an adolescent, middle school aged kid, my dad, and I did a lot of things with my dad. We would take food to people up the hollers and things, trying to help people, hauling kids to vacation Bible school.
And just so our listeners know, Holler is a community. It's
it's a place
okay.
up between two hills.
You are talking of
people
a geography that maybe those on the west or the east may have never heard of. So.
Probably not. And so we were doing a vacation Bible school in a place up the holler, and we had a visiting a pastor, and he was speaking in the evenings. And I think I was about 14, and I made a public commitment. I felt very strongly, specifically called by God to be a medical missionary. I didn't know what that meant, and even my father later said, "Well, son, now." God won't hold you to immature statements of enthusiasm.
Where would you have found out about medical missions? I mean, this is about as far away.
Yeah.
There was nothing up to that point in terms of
I had
visiting
heroes.
missionary? Okay.
I read a lot. I loved science. I wanted to be a doctor. I wanted to help people.
Okay.
And I loved reading biographies of people like Albert Schweitzer and the big heroes, So that was a part of my thinking. So from that point on, that was in the background of my life. So went on, finished high school there at good old Pikeville High School, and went to a small Christian college in Kentucky called Georgetown College. It's where my father had gone to college. Met my wife, Cindy. And then the Lord has done a series of things in my life that don't make sense. And one of them was He allowed me to go to Hardvard Medical School. There was, it would have been an extremely long shot, especially coming from a small, unknown school like Georgetown College. But I'm thoroughly convinced that I got that privilege because the Lord.
But there was a key. You applied.
I applied.
So
yes.
here there was some level of faith in there, someplace.
My wife made me apply.
Really?
Yeah. I said that's a crazy idea, and she said no, just apply. So I did, and we got in. So I'd hardly been anywhere out of Kentucky really, and then we moved really sight unseen to Boston to go to medical school, and that was a whole social and cultural education for me.
Because you'd never really now been in a quote-unquote big city.
No, I had not. I had not driven in a city, and it was very anxiety-provoking for a while, but I loved every minute of it. I felt like it was such a privilege to be there and get that kind of education. So after that, after going to medical school or being in medical school, I made the decision, as my interests directed me, to do something in the realm of neuroscience, the brain, and decided during the course of that I was more of a surgeon than a medical type of person, and so I decided to do neurosurgery. So I did my neurosurgery residency training in Cleveland. That was 7 years. Then I came back to Boston because I loved working with kids and I loved pediatric neurosurgery specifically, and so I did my fellowship at Boston Children's Hospital. I was the first pediatric neurosurgery fellow there, actually. There were very few of those kinds of opportunities in '91. And
back then, where is this situation that happened back in the holler where you had made some sort of a commitment? Was this kind of still active in your own brain and heart, or was this something that was on some back file that covered over with other things and responsibilities?
Some of both. Okay. I mean, it was sort of a drumbeat in the background, while at the same time I was pursuing the opportunities that were before me, and also following my own interests. I tried to be anyway, very prayerful about it all the way through, and at every point I felt like I was doing at that point what God was laying before me to do. But there was always, I didn't know what that calling meant, to be honest with you. So when I finished my fellowship, I took my first job, which was I went back to Kentucky. I was the pediatric neurosurgeon at University of Kentucky Medical Center. A lot of my patients were what I called my people from Eastern Kentucky, and they liked it that I had come from there, and it was wonderful. I was at University of Kentucky for about 8 years. I hadn't been there very long, though, before I started casting around about what to do with this sense of calling, because that was starting to become more and more a restlessness for me. And as my wife will tell you, it was a real restlessness.
Was it a restlessness for her as well?
It was not.
Okay.
She kind of hoped that it would go away.
Yeah.
We were quite comfortable. We had by then we had 6 children, and we had just after we'd been in Kentucky about 5 or 6 years, we bought a small farm, built a house that just suited us, and it was just.
I think I get why she was maybe.
It
not
was
so
wonderful.
anxious.
Yeah, and my parents lived not far away, so the grandparents were there and so forth. But I just became steadily more restless with this sense of calling, and so I started asking around and even applying to mission organizations, saying, "Here's what I do. Can you use me?" And they would usually say things like, well, that's a neurosurgeon, huh? Well, that's great. Do you deliver babies? Those kinds of things. I had one organization tell me that if God was calling me, that Jesus calls us to lay down our nets and follow him, which for them meant I needed to lay aside neurosurgery and go with them and do public health and vaccinate chickens and things like that, which those are valuable things. But I told them, I said, I have spent so many years on this path that I think God has brought me along, that he would have to audibly tell me to change course before I would think that was the right thing to do.
Did you see these kinds of things that were coming at you that were, sounds like basically negations of
Lots.
What you had been calling for? Did you see these more as kind of checks? Or did you see these were you wrestling with these as stop signs? Were these kind of, narrow the focus, stay on the vision, or, have we had enough? Stop.
No.
Listen to your wife. You got kids at home. You got a farm, etc.
Yeah, no, it wouldn't. The Lord wouldn't leave me alone, and but I knew that it wasn't something I could do on my own. So we got to a point where about a year before we finally moved to Uganda, my wife felt very strongly. She says almost audibly. That the Lord separately told her, this is what you need to do. This is what we need to do. And also separately, in my own devotional life, I felt the Lord was telling me it was time. So Cindy and I wrote a letter to family and friends, quite a number, the usual Christmas list, And we said, we don't know what this means, and we don't know what we're going to be doing or where we're going to be going, but we just want to make a public commitment that we think God is leading us to do something along these lines, and we want to make that public.
So this sounds like instead of the two of you perhaps having pillow talk about a vision that you've had that now she shares, you're now asking a community, in a sense, to hold you accountable to a trust that you're now going to hold to.
Yeah. And so within a year of sending that letter, we were living in Uganda. And the way that came about was I had gone to do a short-term trip in Kenya to a place called Kijabi, where there was a general surgeon I had begun corresponding with by email, who was doing his best to treat children that have especially the two conditions, hydrocephalus and spina bifida. He had not been trained to do this and was trying to do it on his own because there was no place for these kids to go. There was a huge volume of them. So I was typing him lectures and, mini lectures, answering questions, and finally I said, I should just come and teach you to do some stuff. So I took my oldest daughter, Joanna, who was 13 at the time. It was our first time in Africa at all. Went to Kenya, spent 3 weeks, realized that there was an enormous amount of work to do there. Unlike what other people might have thought, there was a role for what I could do. And as a result of that trip, I met a man named Scott Harrison, who was the founder of an organization called Cure International today.
We've actually had him speak here a number of times.
Okay.
He's a big friend of the gathering.
He played an enormous role in my life because when I met Scott, he had only built the one hospital in Kenya. He had a vision. He's an orthopedic surgeon by training. He had a vision for building orthopedic hospitals. I shared with him what I perceived as a need in that part of the world that was just really wide open. Nobody was doing this. And I said, what would you think of building a Cure neurosurgical hospital instead of an orthopedic hospital? And he gave me a shot. He caught the vision. And so we planned to move to Tanzania. It's not where we wound up. But Cure had a project going there with another organization, and I went and visited Dar es Salaam. It seemed like a great opportunity, mostly Muslim, could have some university connections there. It was a big city. I resigned my job, and we had the movers pack what things we were going to take in a container. It was headed for Dar es Salaam, hadn't left yet. And then one evening, within a month of our move, I got a call from somebody at Cure who said, "Ben, we don't know how to tell you this, but that project has fallen through. We can't send you to Tanzania." So Scott and his wife Sally came and spent the weekend with Cindy and me, and we prayed and talked. And he said, the only other hospital we have on the horizon right now is in this place in Uganda. It's in a place called Mbale, Uganda. At the time, I knew nothing about Uganda. All I could think of was Idi Amin. Of course, that was decades earlier, but
the impact is still there.
Yeah,
but
right,
it happened
right.
some time ago.
So my wife, I don't know which of us said it. It could well have been Cindy, but the answer was, we feel like God called us to Africa to serve these children. We don't feel like He specifically called us to Tanzania, so wherever there's an opening, we'll go. And so that next month, we took our kids and moved to Uganda.
And the year that would have been was around
2000.
2000. So this is before the influx of South Sudanese coming across the border and the refugee situation.
Right. This was just before all the activity with Kony and the Lord's Resistance Army and the issues of South Sudan. That came along while we were there.
Talk a little bit about, just so we're kind of on the same page, hydrocephalus, this water on the brain. If it's not treated, what happens to a child?
Within 2 years, by the age of 2, about half will have died. The survivors have really big heads.
So it's an issue of drainage. You've got to find a way to get that stop or
the
stem.
brain makes this fluid, this cerebrospinal fluid, all the time, and it pulsates and circulates throughout these chambers in the brain that we call ventricles. And there's supposed to be free circulation between the inside and the outside of the brain. The brain makes it gets absorbed by the vascular system, and there are a number of different ways that you can mess that up. You can be born with a congenital anomaly where it's not working properly, or you can have something happen after birth. The most common in the United States is a baby born prematurely who has a hemorrhage in the brain and has post-hemorrhagic hydrocephalus. We don't see that in East Africa because children that are born very prematurely don't survive. But what we've learned after being there a couple of years and later finally published a big report on this in 2005, 60% of the babies we were seeing didn't have hydrocephalus when they were born, but developed it after an infectious, a febrile illness within the first month of life. So it was a neonatal infection problem causing, and one of the ways we figured this out was with this endoscopic technique that we helped develop to treat the hydrocephalus in those kids. We were actually looking inside the ventricles of their brain and seeing pus, and evidence of scarring and old inflammation. So there is an enormous burden of this disease in the world. We estimate about 500,000 new infant cases per year, and the vast majority of that occurs in developing countries, probably about 200,000 a year in sub-Saharan Africa.
Now, my very elemental research talked about these shunts that, or the typical way of drainage, but that actually becomes cost prohibitive, mechanically prohibitive in the communities in which it sounds like you were serving. So what did you do? Because I would guess the science that you came in with wasn't necessarily the science that might carry you through with this needy population.
Yeah, the only way I had ever treated hydrocephalus in my practice in the States, and the only way I'd seen it treated in my training at some very good institutions, was to put a shunt in these babies, which is a tube that goes in the brain. Yeah, it's connected to a little valve under the scalp, and that connected to a tube that slides under the skin, goes down to the abdominal cavity. And that works. The problem is it almost always fails. Half of those will fail within 2 years. Nearly all will have failed at least once within 10 years. The average child has 2 or 3 malfunctions that require an operation to fix it. Some kids have dozens or even scores of these malfunctions over the course of their life. And the real issue is that when you're a baby and your head can get bigger, a shunt malfunction can sort of manifest slowly, and it's not such an emergency. Once they get past about the age of 2 and the skull is more solid, it's a neurosurgical emergency because the pressure rises, and without an emergency operation to fix the shunt, they die. It's the same here in the States. We fix shunts all the time, 2 o'clock in the morning, because it's an emergency.
But you would be the
operation.
only doctor for how many people in Africa?
Well, since we covered, we had kids coming to us from all of Uganda, Western Kenya, Southern Sudan, parts of Tanzania. These were kids that we would put shunts in and never see again. And and I knew that for more than half of them, when I put this shunt in, they'd go away and it would fail at some point in the next few years, and they would probably die. So we were replacing their existing condition of hydrocephalus with a different condition of shunt dependence.
And a short-term fix.
A short-term fix. Also, shunts in the States are very expensive, a couple of $1,000s for the kinds of shunts we use here. We did show that you could use a very cheap shunt made in India that cost $35 and have the same outcomes at 1 year as used in an expensive North American-made shunt. We did a randomized controlled trial, published that. The big company that makes shunts here was very unhappy with me. But
yeah, you're still on the hit list, I think, with that particular company. But that, in essence, you could not continue doing that. So what did you do?
Well, there was a technique that I had never seen in my training that was starting to be used in selected types of hydrocephalus in older children and adults. It was called an endoscopic third ventriculostomy, or an ETV for short. You put an endoscope into the enlarged ventricle of the brain. You make an opening through the floor of what's called the third ventricle, which is all that separates the inside fluid from the outside fluid. And that, in essence, bypasses obstructions and can treat the hydrocephalus in a lot of cases. The problem was people had tried it some in babies, and it was very unsuccessful. It failed most of the time. We were sort of friends with an organization called the International Federation for Spina Bifida and Hydrocephalus, and they were very interested in trying to bring this technique to the developing world, and they wanted me to try to develop this. So because of that, they donated an endoscope, something I had zero experience with. It came in a box. I put all the tinker toys together, figured out how it worked. And then there was a neurosurgeon in the States, very well-known pediatric neurosurgeon who's about 10 or 15 years ahead of me, named Leland Albright. And I emailed him and I said, Dr. Albright, have you ever done an ETV? And he said, oh, I've probably done about 20 of those now. And he was coming to the region anyway for another reason. I said, would you please come and spend a week with me? So we, in a week, we more than doubled his experience. And we started doing it. And what we found was that we were able to avoid shunts in some of the infants, but the failure rate was pretty high. to jump ahead and make a long story short, there was an old concept that had been used in the early 20th century before there were shunts or any way to treat hydrocephalus of cauterizing some tissue inside the brain called choroid plexus. Plexus makes some of the fluid. And when I looked back at these old papers, I saw that there was some marginal success with doing that. The main problem was using the instruments and the techniques and the anesthesia of the day. The mortality rate was very high. But there was some promise in being able to incorporate that now with better techniques and safer anesthesia. So I began adding plexus cauterization to the ETV procedure that hadn't been done before. And we did a large series where we had the babies that had only had ETV and the ones that had had the combined procedure, and published in 2005 showing that there was a significantly improved success rate with the combined procedure, and we could treat most babies of all types of hydrocephalus with this technique.
Now,
Not all of them.
What
but
kind of success rate are we talking here?
Depends on the cause of hydrocephalus. I'll give you an example. Many children with Spina Bifida also have hydrocephalus, probably at least 2/3 of them. When I was in residency training, those kids almost all got shunts because they taught us that 90+% were going to need one anyway. Turns out it's not quite that much, but there was. We did have some experience with doing ETV by itself in those children, and we had about a 35 to 40% success rate. When we added plexus cauterization, which we call CPC, that more than doubled the success rate to 75%. And in all comers, all types of hydrocephalus, all babies under a year of age, we could successfully treat about 2/3 of them without the need for another operation after that.
That means they're going to live to the ripe old age of whatever.
Whatever else limits them. I mean, in Uganda,
Sure,
there's
sure.
high, childhood mortality and so
Sure.
forth. But yes, it for those kids in which it's successful, it removes hydrocephalus as an issue from their life, and they're not dependent on a device. The other thing about it is that, and you've kind of got me on my soapbox here, and I'll shut up in a second. But when this procedure is not going to work, it almost always fails early, and nearly all the failures occur before 6 months. And that's in sort of a safe zone when the baby's head can expand, mom has time to come back. If you get out to 6 months, essentially we're done. Very different from shunt dependence, which over the course of your entire life, there's always the risk of a malfunction.
Now, you came back to the United States at some point. Why was that?
Well, I told people when we went to Uganda that I'd like to work myself out of a job. And the Lord allowed us to do that. He sent me a very fine Ugandan man who had done his neurosurgery training at University of Cape Town, which is a very good place. He'd come back to Uganda to try to practice at the government hospital in the capital city, was totally frustrated by that, couldn't do what he was trained to do, and had decided to go back to South Africa, where frankly he could make money. And I met John Mugamba. I offered for him to be my fellow for a year. We had some funding to do that. So we hired John. He worked with me for a year. Then I hired him as my partner.
Wow.
Made him assistant medical director. And then within 3 years, I think it was very clear that I didn't have to be there. And we also had other people. Our next person that's now the current medical director, Dr. Peter Senyonga, another Ugandan that worked with me in Uganda for 3 years, wanted to become a neurosurgeon. We finally got him into University of Cape Town. Cure sponsored his training for 5 years, and now he's come back. And we've done that with 3 other Ugandans now, have brought them through the program. They work for us and with us, and we have another one in the pipeline now currently at University of Cape Town. So really we have this, going now, and the hospital in Uganda is completely staffed by Ugandans. There's not a There's not an American in the
It's
place.
got to be a huge level of satisfaction for you.
It is. But the other thing that we tackled while we were there was that this was a very unique island in the middle of a great ocean of need. And we wanted to start training and equipping other surgeons in other countries to do this. So we developed a program that we now call Cure Hydrocephalus, where we bring surgeons from mostly neurosurgeons. We've trained some general surgeons, but mostly neurosurgeons in other developing countries, brought them in, have kept them in Uganda, which is the best place to train, for 2 to 3 months, trained them. If they become competent, we provide the equipment. We send them back to their home hospital with the equipment. We provide maintenance on the equipment. We hire a local person who's a Christian to be the clinical care coordinator. Their job is twofold. One is we showed in a study that the biggest cause of mortality was just not being followed up on. And so the clinical care coordinator needs to make sure that these kids are followed up on, especially in that critical first 6 months. They do home visits, they facilitate their trips back and that sort of thing. And also their mission is to develop an evangelical relationship with the family to lead them to Christ and get them plugged into the local church. We've done this now in 20 countries, and we're still doing this every year now. We train a few of these people and equip them. And it's a network that we have that we call our Partner Treatment Network.
Now, this has obviously been recognized. 2012, MacArthur gave you a $500,000 prize. Tell me about that. That's quite an award.
Yeah, it was a huge surprise and a huge honor. It was, and it's kind of a big deal, and so it's given me a voice in some ways, or a little bit of cachet or something that I might not have had. Again, I believe this is all in the Lord's plan. So yes, it was $500,000. We actually donated that to a trust, and it's called the Global Hydrocephalus Spina Bifida Fund, and we draw the interest out of that to fund some of the things that we're trying to do in Africa.
Now, you've just given a breakout class this morning here at the gathering, and I was able to meet with one of your colleagues on the panel, and she was stating that these courses are typically not well attended, that this is not an issue of disability, kind of the general category of disability for which either the church or Jesus followers have shown a great deal of interest. Why is that, and what in your mind needs to happen so that with the numbers you're talking about, it sounds like the church needs to wake up?
I think the church does need to wake up. There are lots of reasons for this, I think. People are very uncomfortable with other people with certain sorts of disabilities, cognitive disabilities or disabilities that make someone very dependent or make them look very different. It's our human nature to feel uncomfortable, I think. And we sometimes don't know what box to put people in. We're very much categorical thinkers, and we sort of manage our perception of the world by putting people into categories. So you're either disabled or not disabled. You're either normal or abnormal. But the lines are very much blurred, obviously, and it's not that black and white. I think everybody, including the church, would just as well not think about disabilities. It's inconvenient. It's not sexy, and it's the kind of thing that would just be much easier if it would go away. But about 1 billion people in the world are significantly disabled, with the definition of disability meaning they can't engage in normal activities of life.
So about 1/7 of the world is dealing with some form of disability.
Yeah. Not surprisingly, the majority of those are in developing countries.
Sure.
Another thing that I think changes our perception of especially congenital disabilities in this country, in our culture, is that we think kids that are born with Down syndrome or some significant orthopedic deformity were mistakes. They shouldn't have slipped through the filter, because we can prenatally diagnose all these. For instance, 92% of children diagnosed with Down syndrome are terminated during pregnancy. So it's wiping out a whole genre of people. And I do a lot of prenatal counseling. It's part of what I do at Boston Children's Hospital. So mothers that have children that have been diagnosed with brain or spinal cord anomalies, a lot of it's spina bifida, hydrocephalus, but some other things too. They come to the Advanced Fetal Care Center, where they learn about, we do some advanced imaging, fetal MRI. They meet with the appropriate consultants, and it's me if it's a neurosurgical issue. And oftentimes they're there to decide whether or not to let the child live, whether or not it meets the level that they need to meet. I try very hard to go against the culture in this. When I first went to Boston, I think I was met with some surprise and some resistance in my approach to this. But whenever I counsel these parents, I say this. You usually know if it's a girl or a boy. I say, you know what, your son or your daughter has this condition. I explain it. These are the kinds of things you're going to need to do when the baby's born. These are the kinds of things that are going to be challenges. But then I usually say something like, but this is going to be a little boy that you love. Mm. And sometimes I win and sometimes I don't. Occasionally, not very often, but when it seems appropriate, I will share with them my own experience of being a parent of a child with significant disabilities.
And a son of a father who also had a disability. Mm-hmm. Where are we going to see you in 3 to 5 years? Can you broadcast? Can you look out that far? Be a little prophetic. Your career sounds as though it's one that you've discovered as you go along.
Yeah.
But is that the same way as you've come into this next phase of your life when you've come back to the United States?
Yeah. You know, I have students come and talk to me and ask me my advice on how to plan their career.
Sure.
And I usually say, look, I didn't plan this. I just one step at a time did what I thought God was asking us to do. And I've told my own kids that I see life as sort of like riding backwards on a donkey. You can only see where you've been, but you trust the one who's leading the donkey. And that's really the way it's been for me. All of these, the MacArthur Award and being a professor at Harvard and all this stuff, I never, ever, ever would have thought about any of this, much less having an opportunity to develop a technique that now we're starting to use in the United States. We've trained a lot of people across North America to do this, and it's starting to be adopted in a lot of places. But I really think that God has put his blessing on this, not because of me, but as a result, perhaps, of my being willing to do what I thought was being obedient.
Let me finish with something I saw on your website, which actually was almost the first thing I saw on your website. Okay. And I quote, "I'm guided by my Christian conviction to use my skills as a surgeon and scientist for the good of others, and am an advocate for children who have complex medical needs in their families, both here and the developing world." I would have expected something that clear and that out front to possibly be on maybe a familial website, but I was looking for information for you at Harvard University. That's pretty out there.
Yes, it is.
Tell me about the reaction to that from others and kind of what's happened as you've talked about your faith so boldly.
Yeah, well, I don't do it as boldly as I should, but I try to be upfront with people. And that little biography was a result of somebody coming to me and saying, we need to put a biography of you on the website, and you tell us some things about yourself. I said, I have to be honest. I said, you might not be comfortable with what I'm going to tell you, but I have to be honest. And she said, oh, sure, be honest. So I started talking, and there was a little bit of a glaze over the look, but they honored my request, and they pretty much put in what I said, and I've been thankful for that. Harvard and Boston Children's are not Christian institutions, to say the least. And I've been feeling my way along about how you navigate that in honesty and in love, and in a way that doesn't sort of torpedo the whole thing, because you could easily do that. People accept me. They know I'm the crazy guy that was a missionary, and I'm religious, but that's okay with them, because I do a good job. So it's been. The other thing that's been good is that my daughter Sarah, who's needed quite a number of operations because she gets these tumors that turn malignant once in a while, she's been in and out of Children's Hospital for the last several years. Well, she's a young adult now, and people know my daughter, and people in the operating room very frequently, probably at least weekly, will say, "Hey, Dr. Warf, how's Sarah doing?" So they know me from both sides.
Well, today we know you a little bit better as well, and we're so grateful that you would join us today. Thanks for being with us and sharing with us at the gathering.
Thank you.